So there is no good evidence that arterial resections during right-sided pancreatic resections are of benefit. They may indeed, and this is the UK voice, be harmful with increased morbidity and mortality and should not be recommended on a routine basis. Patients categorized as borderline resectable should undergo surgical exploration in order to obtain further verification of any arterial infiltration. And this is the point which I stressed before. Once the radiologist or the oncologist will tell you, I have the suspicion that the arteries are involved or at least stuck to the tumor, there is a very high probability of more than 1/3 that this is mimicked by a pseudotumorous infiltration, so-called what I call retention pancreatitis, or a fibrosis due to a chronic retention pancreatitis, which mimics tumor infiltration. In fact, there is no tumor infiltration at all. And this is present in 1/3 of the patients, so I think in these patients, in every patient, such a patient warrants surgical exploration to justify whether this is a true arterial infiltration or not. And these explorations usually take 3 to 4 hours in our institutions, but we make a very, very hard decision when once we decide that the patient is irresectable. This is probably due to the fact that arteries beyond technical reconstruction are involved. So, in case of verification, palliative treatment is the standard of care. Now, of course, we have to respect the comorbidity of these patients, the tumor biology, the performance status, and the patient age. And this is a multidisciplinary decision. So in a young patient with an infiltration of the celiac axis, I would go ahead and do a total pancreatectomy with a celiac trunk reconstruction right away. Because there is no level 1 evidence to recommend neoadjuvant therapy regimens in patients with arterial infiltration, and therefore evaluation of neoadjuvant therapeutic options are only recommended in the setting of prospective trials. And this is just a qualified recommendation. So even there was no consensus between these centers. If neoadjuvant therapy regimens are applied afterwards, an exploratory laparotomy and attempted resection should be considered in the absence of disease progression after neoadjuvant treatment. And again, straightforward resections have a role only in clinical trial setting. So this is the consensus statement. I will not focus on the workup, the pathological workup of the specimen. You are well aware of the fact that if you follow the Leeds protocol or the recommendations of the Royal College of Pathologists, then your R1 rate, which used to be just 20%, moves up to 80% if you do a through examination of the pathological regimen. So in fact, all our survival data are probably based on the majority of patients where we did an R1 resection, because your true R0 resection rate is just 20% in all the cases which are resected in curative intent. So the prognostic relevance, patients with borderline resectable tumors and with suspected but not proven distant metastasis, and also patients ineligible for surgery because of comorbidity should always be re-evaluated for surgery after multidisciplinary supportive treatment. I would have been very keen on listening to your expert on nutrition in pancreatic cancer patients, and referring to your question, CA19-9 and serum level information may be included in standard preoperative diagnostics for patients with borderline resectable disease to assess the potential survival benefit from surgery, but not for prediction of resectability, except for when we suspect peritoneal metastasis. So again, from my experience, you know that I was trained in America, and from my experience and from my friendship with US surgeons, I strongly say that although the NCCN guidelines are very aggressive, the surgical practice in America is not very aggressive. This probably is due to malpractice reasons and so on. That's the reason why I have seen many patients in America when I visited my friends at Mass General or Hopkins, my old alma mater, that I have encountered patients which I would have resected right away, which were treated there as borderline resectable. And again, just to rule out this, we have established this multi-center neoadjuvant radiochemotherapy trial, which is running in Germany in 20 institutions, and it's a randomization between two groups. One is in borderline resectable and clearly resectable patients, and they go up front to surgery. And the other group is randomized to neoadjuvant chemoradiotherapy, and then they go to surgery if they have no distant metastasis progression. I have to tell you that the recruitment for this study is very low because the wish of the patient is, I want to have the tumor out. If you can have the possibility to cut the tumor out, take it out. And believe me, in my practice, we see 250 patients eligible for resections. I think we have randomized now 15 patients in 1 year. It's very tough to get these patients into this trial, and I think we have to close this trial prematurely because the patients don't want this neoadjuvant therapy. Thank you very much.
Thank you very much, Professor Izbicki. So the presentation is open for discussion.